Today is we will be presenting a project that we ran over the course of about 6 months, which was related to maternal health and also infants and young children, health and nutrition within the Māori and Pacific Island sector. So firstly, I would like to acknowledge the traditional custodians of the land upon which we meet today, the Bindal and the Wulguru Kaba people, and pay our deepest respects to their elders, past, present and emerging. And also would like to recognise the cultures that we represent. We represent 7 Pacific Island cultures. So just in our cultural tongue, Bulavanaka, Kia ora ana, hello wantoks, talo falava, malua lele, kia ora and namaste.
Okay, so we're going to start just by giving you a little bit of background on who is the Good Start program, just to provide a little bit of context as to who we are, what we do, and kind of where we sit within the health system. Sorry, the video should play, but... That's okay, we'll just keep going. The video unfortunately isn't working, but that's okay, I can still explain who we are at the Good Start program. We are a Queensland Health Initiative, and our aim is to improve the health and well-being of the Māori and Pacific Islander children and families. So we are a culturally tailored, community-based program that works towards the prevention of chronic diseases. And we specifically tailor our program to 7 of the largest Māori and Pacific Islander communities in Queensland. This doesn't mean we exclude the other Pacific Island nations, it just means that we tailor specifically to those 7 groups. Those groups being Māori, Samoan, Tongan, Cook Island, Fijian, Fiji Indian and Papua New Guinean. What we do in our program, which unfortunately I was hoping to show you on video, is we do a lot of school-based health promotion. So we actually go into the schools and we target the schools that have high rates of Māori and Pacific Islander children attending those schools. And we go in and we deliver health education, specifically focusing on nutrition and physical activity messages. We also do the same thing working in community settings, but working with families as well. A lot of the time, we often get asked why we exist as a program. And yeah, so this is quite, I guess, a passion of mine. We exist because we have been identified as a priority population. So in 2008-2009, Queensland Health Government actually identified our community and conducted a needs assessment. What they found was quite phenomenal. They actually saw a lot of social determinants at play within our communities. So a lot of those related to overcrowded housing, lower levels of education attainment, and I guess higher rates of employment in what they would call low-skilled jobs, and of course lower income, lower wealth, and a community disconnect as well. But what that means when you kind of bring it down to the individual level is we have increased mortality and increased morbidity within our community, increased levels of hospitalisation. We also have things like higher levels of tobacco smoking, alcohol consumption, overweight and obesity, mental health issues and violence in some of our communities. We also have lower levels of health literacy, help-seeking behaviours, access to services, and again, those income and education things come up as well. To put that in a little bit of perspective for you, because sometimes between all the stats we get a little bit lost, if you were born in Samoa, you would be 3 times more likely to die or to get diabetes. You would be 7 times more likely to have an illness related to that diabetes. You would be 4.5 times more likely to be hospitalised, and you would be twice as more likely to die from an avoidable condition. So when you put it into that kind of context, it kind of hits home as to why we exist as a program. So now we're going to talk a little bit about the Good Start to Life project. So this is a new project that came outside of our school-based health promotion and our community-based health promotion that really focuses on maternal and infant nutrition. And again, we often get asked, why, as a preventative health program, are we going into maternal and infant nutrition? And this is because that has now, a lot of the research and emerging evidence is saying that health and well-being from pregnancy through the first few years of life lays the foundations for long-term health outcomes. So we see that as an opportunity to address childhood obesity and work towards the prevention of chronic diseases, which is our ultimate goal at the Good Start program. We then kind of had a little bit of a look deeper and had a look at, okay, so all this research is coming up, but why should we think about this in terms of our community, our Māori and Pacific Islander community? We worked closely with a lot of hospital and health services to identify what sort of issues in terms of maternal and infant health they were facing. And we saw some really, really interesting data pop up. So at Metro South Hospital and Health Services, the women from Māori and Pacific Islander backgrounds who were birthing there had more than double the rate of gestational diabetes than the average Queensland person or woman delivering. We also had a rate of overweight and obesity at time of birth that was higher than the statewide average. And we also have, again, low levels of exclusive breastfeeding and early introduction to solids as well. Other factors include lack of culturally appropriate antenatal and child healthcare services, and the same with resources as well. So a lot of the community we consulted with said there's just nothing that meets their needs. And we also, again, see health literacy coming up and the cultural reluctance or disconnect in order to seek that support that they need. So what did we do with all of this information in mind and with our broader objective in mind? We knew we had to do something. So the first thing we did was establish a consumer engagement strategy, because we knew that the community was needed first and foremost to decide how we were going to tackle these things and empower the community to choose health. The secondary to that is we created the Good Start to Life project. So we didn't just create it, we consulted with the community first, and then we created this project. So basically, it is a preventative health strategy to build community knowledge around the importance and appropriate use of antenatal and child healthcare services. It's a bit of a mouthful. We also obviously promote recommended nutrition and healthy weight gain in pregnancy, promote and support women to breastfeed, and promote and support families to adopt recommended infant nutrition guidelines. The first stage in the Good Start to Life project, because obviously this is a huge project and we only just started this last year. The very first stage in consulting with consumers is we found that they were wanting more than anything else to have resources that they could take home and read and understand what was happening during pregnancy and throughout infancy in terms of health and nutrition. So that's what we decided to start with. I'm going to hand over now to Alofa because from deciding to develop resources, we then took that a step further and said we don't want to create resources for the community, we want to create resources with the community. So we did that at all phases and at all stages. And I'm going to hand over to Alofa because Alofa was involved in a lot of phases of this co-design. And I think it's best to hear from her experience and her viewpoint as to how she felt as a consumer involved in this project.
So what we did with the Good Start to Life project was we knew that the community that we were serving, there was a disconnect between the information that was being provided to them and also the services. So in real time, you'd have mum that goes to the doctor when she finds out she's pregnant. You won't see mum again until she's having the child, because there's low levels of literacy within the community and also a misunderstanding on the information that was given to them. So we also found that there was just there wasn't a trust relationship with the community there. So what we did is we brought in a model where we engaged the consumers at all levels of the project. So I'm the consumer rep on the steering committee. So at all different phases of the project, we brought the consumers along with us. So they were involved in the project management of it, also the strategic level, but also right down to the graphic design of the resources. And also we checked with the elders of the community that it was appropriate. There were some photos, for example, where just in our Western world that we grow up in, we wouldn't think it was too much skin, but we would take it to our community elders and it wasn't appropriate. So there were just things like that we checked along the way. What we found with this model to set up, especially the representation at a strategic level, it was a new model for Queensland Health for the area that we went into. There was a bit of trepidation there because there is sensitive information at that level. You're now privy to information like budgets, funding, any other politics that might go on. So it was a very stringent process to make sure that the information that's discussed just stays in that room. And I believe that it was actually, even though it took a while, probably about 3 months for all those checks and balances to be put in place, it was worthwhile because that level of representation at that strategic level is what the people saw, the community, and it just made them more open to the resources when we actually launched it. So just going back to our design, so we had consumers involved at the strategic level, and then also consumers involved in the where they were giving us the information on what needs to go into the booklets, and also consumers that they actually created all the resources. So we had. So I should mention actually, we were also very mindful on how we approach the community. So it's not always, we found that we didn't find success in creating, say, like a forum like today, turn up, register. We would have low attendance. Some of these things we had to really think outside of the box, possibly go out to the churches where they already are, to some of the mothers groups. We created some mothers groups as well, where the mothers go and drop their children off to school and they're hanging around. So we actually created a mothers group around that sector. Just skipping through them, sorry. Okay, so that was probably the gist of the consumer engagement. I think the main thing that we wanted to really get across is the level of involvement throughout the different project phases and at the different levels as well. We found it was successful. We did find that there were some learnings and some opportunities there that we're discussing and just always checking on, and just for future, because we do plan to go into future phases of this project. For example, we're looking to start doing cooking classes for mums and for children as well, for young ones. Right. Cool, so I'll now hand it over for the rest of it.
Thank you so much to Alofa for her insight. I might just quickly flick back and share my perspective on, I guess, having consumers involved in the co-design process. like Alofa said, her involvement at the strategic level, having consumers involved at a creational level, and then actually having consumers participate in the photos and the graphic design. So having them involved in all phases of the development was really fundamental for us to create appropriate resources that the community wanted, not that we wanted to give them. So I, again, want to extend my thanks to Alofa for being so involved in that process. I have been told we are running short on time, so I might quickly glaze over these sections. But within all of the consumer design process, we also had other factors that we had to consider. So we had to ensure that these resources met current best evidence-based guidelines. So we met with multiple health professionals and health services to ensure that we were incorporating those guidelines, but again, took those back to the consumers and said, how do we make this appropriate? Is this something your community wants, needs? Do they even have this practice? So that was considered. We also met with international preventative health organisations as well to have those same discussions. And again, we used just a cyclic methodology of review. So we started with those guidelines, got feedback from everyone, evaluated that feedback, created, and then took it back to them and reviewed. And we used that kind of cycle until everyone was happy. We didn't progress anything until all of our consumers were happy, and also the health professionals as well. It's just to get that balance. We also considered quite highly the literacy levels of our community group, because it was so highlighted within our needs assessment that literacy, health literacy specifically, was an issue within our community. We considered it quite highly on our agenda. But the key thing was, it was our partnership with consumers that led us to have low literacy resources. When there were words in there that could not be understood, it was picked up before the resource was published by the consumers. And it actually led us to have a Flesch-Kincaid grade level of 4.5, which is actually really, really quite a low level of health literacy for an education document. So it makes it a highly recommended resource. So what we ended up with was consumer-driven, user-friendly, culturally appropriate, low literacy resources. So we ended up with 4 booklets and 3 posters, and that encompasses health and nutrition from pre-pregnancy through to when kids are 4 years of age, and they're designed to improve the knowledge, skills and confidence around maternal and infant nutrition, and ultimately contribute to the prevention of childhood obesity and long-term looking at adulthood obesity and chronic disease. So these are our Good Start to Life resources. We have brought some up today, but my check-in luggage wasn't that extensive. So I could only bring 10 of each booklet up, and I'll have them at the CHQ stand if you would like to have a look at them. So we actually started with preconception, so getting ready to have a healthy baby, because from our consumers we found that they were telling us that they needed to hear this information before they were pregnant, and it needed to be highlighted at that stage, not just at pregnancy. So we ended up with 4 booklets when we originally thought we might have just 3. And this is the beauty of consumer engagement, is we're forced to think outside the box, but we end up with something that the community wants. So the other thing for us at the Good Start program, we are a culturally tailored program, and we didn't feel it was appropriate to end our relationship with the consumers at the finish of that project. So we decided not to stop our consumer engagement there. So we held a launch of our resources, but the consumers were the guests of honour. So The directors and all the preventative health experts were also invited, but our consumers were the guests of honour. So not only was it culturally appropriate, but it just recognises the significance of their contribution, because without it, who knows what we could have ended up with. We also found that we're also continuing our relationship with those consumers, and they're going to feed into our bigger and broader objectives, so it fosters long-term involvement in our program. So our key learnings from this project is, number one, consumer involvement is fundamental. So I've said that so many times already in this 20-minute space. But basically, we were able to effectively cater for the wants and needs of the community. We were able to appropriately discuss sensitive topics, which again, Alofa highlighted for us. So culturally, there are things that exist such as men's and women's business, and we needed to be respectful and mindful of those things as well. It allowed us to tailor for cultural differences, because even though we share similarities as Pacific people, we acknowledge that there are all differences as well. And we also found that that kind of cycle methodology allowed us to keep tapping in with consumers and saying, hey, this is how the project is going. Would you like a little bit more info? Would you like to feed back more into this? Some of our broader learnings just from doing this project, we now know that consumer engagement is really the underpinning of all preventative health projects. So it allows health professionals and health services to decide with the community, not for them. It creates community ownership. So our community members that were involved in this project, so there was a total of over 100 consumers involved. They now feel ownership over these resources and have continued the distribution of these resources. We have created long-term relationships. We also learnt that consumer engagement is really dynamic, and we as a program have to be flexible. So even though we might be rostered to work 9 to 5, we need to be mindful that so our consumers might have that same roster. So we need to be flexible in the way we communicate, whether it be face-to-face at a time and a location that's appropriate for them. If they would prefer a phone call, that's fine, we'll give them a phone call. If they want to email, awesome, we'll email. It's no problem. We have to be flexible. We believe these broader learnings can extend to other projects, not just our program, but also other hospital and health services. So where to from here? Again, we say this, the resource development phase of the Good Start to Life project was only the start. So we have a lot more to go. And I might actually invite Alofa to talk about where the Good Start program is going to from here.
So on our charter, we do have it is quite ambitious on the entire program, but just with regards to this particular project, we are looking at doing education sessions with the mums and the children as well. Through this, we kind of recognised that we forgot about the dads, and so they felt a bit, dads always do the job behind the scenes and quietly do so. So we're looking at bringing out some resources and support for the fathers to help them to support the mums. We are looking at doing more cooking videos. So through this, we're also looking at developing our social media a bit better. So our actual strategy on how we reach our audience out there, and also actually going into the community just at times and in a manner that they're used to. So we are starting to utilise the Facebook more, and just show our faces a bit more on Facebook as well, just to keep that connection with the community and the mums. And we're also looking at also making the resources more readily available for everyone. So they're currently available to, you can download them on our website, but we're looking at just making it a bit more broader, and just so that it's more available.
We just wanted to highlight this year's theme of power and passion, because during this project, the Good Start to Life project, we really felt that it highlighted for us how paramount our consumers are, and that it really ignited our passion to always continue and strive to do better in that aspect. And so we've created this culture within our team where it's just what we do every day. It's no different. It's not abnormal. It's just what we do. So every day we're in touch with consumers, wanting them involved, asking them questions, what their wants and needs are. And so we feel now it's just what we do as a program.
All right, thank you.